My today's topic of presentation is pulmonary abnormalities in liver disease and relevance to transplantation and outcome. So let me start with the spectrum of pulmonary disease which we have in cirrhotic patient or CLD patient. So there are three sets of diseases which a cirrhotic patient can have. One is pulmonary complications of liver diseases and portal hypertension like hepatic hydrotherax, hepatopulmonary syndrome, portopulmonary hypertension. Another is pulmonary disease that can coexist with liver disease like asthma, COPD, pulmonary nodules, interstitial lung disease. So even the list in this category is not exclusive. Other entities like non-alcoholic fatty liver disease and obstructive sleep apnea, they can also be comorbid conditions. Another is a set of disease that affects both liver and lungs, like cystic fibrosis, alpha-1 antitrypsin deficiency, and hereditary hemorrhagic telangiectasia, sarcoidosis, COVID-19, and other diseases like autoimmune conditions and connective tissue disorders. They all can affect both lung and liver. So I will be discussing the pulmonary complications of liver disease and portal hypertension first, and then, if permit, the disease affecting both liver and lung last. So coming to this table, which is taken from hepatology, post-liver survival in LT recipients with pulmonary disease compared to general population of LT recipients. So coming to the diseases which are attributable to the underlying liver disease directly, that is hepatic hydrotherax, hepatopulmonary syndrome, and portopulmonary hypertension. So the outcomes are comparable to that of general CLD patients undergoing transplantation without having this hepatic hydrothorax and hepatopulmonary syndrome, and resolution of fluid is expected in hepatic hydrothorax. Resolution of hypoxemia is expected in hepatopulmonary syndrome, but in portopulmonary hypertension, the results of post liver transplant are comparable in highly selected settings, and higher rates of perioperative or early post liver transplant mortality is observed in cases of moderate hypertension. About the pulmonary disease that can coexist with liver disease like asthma, COPD, pulmonary nodules, there is a limited or no data available, and the natural history of disease after transplant is dictated by the same scenario. But in our experience, most of the time, obstructive airway disease, there has been no problem with most of the time. And in my personal experience in the last 4 years, I have seen a single death only attributable to asthma that was also status asthmaticus. And coming to the disease that can affect both liver and lungs, the cystic fibrosis, alpha-1 antitrypsin deficiency, sarcoidosis, COVID-19, and hereditary hemorrhagic telangiectasia, although they are very rare and most of the more commonly seen in Western population, but they are also merit some attention. So I will be discussing pulmonary complications attributable to liver disease. Coming to the hepatopulmonary syndrome, so a brief review of the diagnosis and clinical symptoms. So about the diagnosis first, the diagnosis is made by the presence of triad of these things: patients with the liver diseases and presence of alveolar arteriolar oxygen gradient more than 15 millimeter of mercury or more than 20 millimeter in patients more than 64 years of age, and presence of intrapulmonary vasodilatations. The severity classification, HPS can be classified into mild, moderate, severe, and very severe based on the PaO2 absolute PaO2 measurement and the presence of alveolar arteriolar gradient of more than 15. So more than 80 is mild, 80 to 60 is moderate, severe is 50 to 60, and less than 50 comes to very severe category. So in the clinical findings, we can see cyanosis and digital clubbing. Diffuse telangiectasias can be rare. Platypnea, that is worsening of dyspnea moving from supine to upright position, is sometimes elicitable until unless patient has large volumes of ascites. and orthodeoxia, that is defined by decrease of PaO2 of more than 5% or more than 4 millimeter Hg moving from supine to upright position. So this alveolar arterial oxygen gradient can be ascertained by the ABG, and intrapulmonary vasodilatations can be established by the saline contrast echocardiography or macroaggregated albumin scan. And these have therapeutic implications, which we will discuss in later slides. So a little bit about the pathogenesis of the HPS. So we all know that in the presence of cirrhosis and chronic liver disease, there is a increased endotoxin and TNF alpha flux coming from the gut, which even sometimes liver is not able to hand over, and that also spills in the general circulation coming to the pulmonary circulation also. So also in the presence of leaky gut, there is a endotoxemia, which can affect the lungs directly. So these endotoxins and TNF alpha, they are going to affect the endothelial cells, and this endothelin act on the endothelin B receptor, so leading to the downstream cascade of intravascular pulmonary dilatations. And there is a neoangiogenesis, which is started by the placental growth factors, which are secreted from type 2 alveolar cells and also from the inflammatory cells. So HPS occurs in 5 to 30% of LT candidates. Pre-LT workup is needed because most of the time patients are not symptomatic. Median survival of 24 months and a 5-year survival rate of 23% without any medical therapy or liver transplant. PaO2, that is arterial PaO2 decreases in 85% of patients, and the average rate of decline is around 5 mmHg per year. So in my experience, I have seen nearly 1 to 2% of desaturation in peripheral SpO2 measured in OPDs. So this is again a pictogram depicting the pre-transplant survival on the waiting list in HPS patients compared to non-HPS patients. So the pre-transplant survival is not statistically different in HPS as compared to non-HPS on the waiting list. So in hepatopulmonary syndrome, standard exceptions, that is SE standard exceptions, are allocated to the patient with severe HPS, that is defined by PO2 less than 60 mmHg, and initial standard exception MELD is compatible with 3-month probability of death of 15% is granted within this OPTN network, and the majority of countries in the Eurotransplant also do, as well as with Indian centers. So this policy of accepting the usual MELD calculation norm is based on 2 observations: HP, because HPS is progressive, and post liver transplant mortality is highest in patients with very severe HPS. The severity of HPS does not correlate with the severity of underlying disease also. So 5-year survival of 76% has been observed in transplanted patients with HPS, which is comparable to outcome in LT without HPS. So the strongest predictors of post-LT death in HPS patient are a preoperative PO2 of less than 50, that is very severe HPS, and brain uptake of more than 20% of tracing on macro-aggregated albumin scan. Patients with severe HPS should be managed in specialized high-volume liver transplant centers experienced with post-LT interventions to treat severe HPS. So treatment algorithm in such severe post-LT hypoxemia also includes extracorporeal membrane oxygenation. Complete resolution of HPS following LT occurs in more than 80% of cases, and mostly so within 6 to 12 months. HPS per se represent an indication for LT, but pre-LT PaO2 less than 44 millimeters of mercury is associated with significant increased post-LT death. And 5-year post-LT survival in such cases approaches to 59%, which is still more than 50% the point of futility of transplant. Very severe HPS may be considered as a contraindication to LT. At Eurotransplant centers, also studies evaluated outcome in LT patients who received standard exceptions for HPS compared to matched group with HPS. So survival rates at 1 month, 6 months, and 1 year post LT were 91%, 77%, and 70% in HPS compared to the patient with HPS of 96, 85, and 81%, although numerically low, but statistically not different. So this again, in the Eurotransplant study, this was the first study to convincingly prove that mild exception given to HPS patient does not over prioritize, and in fact the mortality, they are just matching. Coming to portopulmonary hypertension. Portopulmonary hypertension is a rare complication of end-stage liver diseases defined as a pulmonary arterial hypertension in the setting of pulmonary hypertension with or without liver disease, and is included in Group 1 of 2008 Dana Point classification of pulmonary hypertension. It's characterized by elevated pulmonary artery pressure, increased pulmonary vascular resistance as a result of remodeling process. And classification based on mean pulmonary arterial pressure, it is mild is more than 25, less than 35 mmHg, moderate more than 35 to less than 45 mmHg, and severe more than 45 mm of mercury. So portopulmonary hypertension is thought to arise from limited blood flow in the pulmonary arterial circulation because of vasoconstriction. So there are numerous factors which are responsible for this limited flow. One is changes in endogenous vasoregulators, so endothelins, increased levels of endothelins, which induces reduced prostacyclin synthesis from pulmonary endothelial cells, and which induces proliferation of smooth muscle cells, endothelial cell activation, and also because of platelet aggregation. A slide about natural history and prognosis. Incidence is 3 to 10 in case of portopulmonary hypertension. Independent risk factor, females are 3 times more likely to have this portopulmonary hypertension. Pre-existing autoimmunity, genetic variations in estradiol levels, moderate to severe portopulmonary hypertension, and presence of large portosystemic shunts. They are independent risk factors. No clear association between severity of liver disease or portal hypertension and the development of severe portopulmonary hypertension is there. Survival rates at 1 year of between 35 to 46% without any specific treatments are observed, and these are worse as compared to idiopathic pulmonary hypertension, which has 5-year survival of 42 up to 64% as compared to 40% of this portopulmonary hypertension. So the portopulmonary hypertension is a PH arising as a complication of pulmonary hypertension and may result from both cirrhotic and non-cirrhotic causes. It affects up to 5% of liver transplant candidates, and POPH may present with minimal symptoms, but untreated can rapidly evolve, resulting in prohibitive risk of LT. So diagnostic criteria of portopulmonary hypertension defined by presence of PH, that is pulmonary arterial hypertension, mean pulmonary artery pressure of more than 25 mmHg, increased pulmonary vascular resistance, that is more than 250 dynes second centimeter raised to power -5, and normal pulmonary capillary wedge pressure, that is less than 15 millimeter of Hg. So in portopulmonary hypertension, the pre-transplant goals are to have adequate control of pulmonary hemodynamics with vasomodulators, and followed by consideration for liver transplant. Again, standard exceptions in POPHs are available to gain priority for liver transplant. So what are the scenarios? Standard exceptions criteria include the lowering of mean pulmonary artery pressure to 25 to 35 mm of Hg, and along with the decrease in pulmonary vascular resistance to less than 40 9 centimeters second centimeter raised to power -5 in the OPTN network. In those with previously established POPH, so patients are granted initial standard exception malcompatible with the 3-month probability of death of 25% or equivalent in OPTN as well as Eurotransplant centers, and which has to be reviewed after 3 months. But it is more logical to modify standard exception criteria focusing on the improvement in pulmonary vascular resistance rather than the absolute values of mean pulmonary artery pressure. So, what are the current medical and surgical therapies and role of liver transplant in the management of pulmonary hypertension? So, medical therapies, they fall in 3 groups, that is prostacyclin analogs, epoprostenol, inhaled treprostinil, and inhaled iloprost. So there are reports of improvement in hemodynamic parameters, mainly in case report, as well as single center study also reported an improved 5-year survival using intravenous prostacyclin. In the endothelin receptor antagonist group, there are 3-4 drugs, that is bosentan, ambrisentan, macitentan. So prior to the invent of macitentan, bosentan and ambrisentan were used in the management of portopulmonary hypertension, but because of side effects, hepatic side effect profile, we and many of the clinicians are reluctant to use in the child C or even in child B. So, but with this macitentan, the risk profile of hepatotoxicity is less, and this can be used. Phosphodiesterase inhibitor, sildenafil, tadalafil, vardenafil also can be used. So, they also affect the lowering of pulmonary vascular resistance by causing pulmonary vascular dilatation by inhibiting phosphodiesterase enzyme and inhibiting the growth of pulmonary vascular smooth muscles. Sildenafil has shown to improve exercise tolerance and has an excellent side effect profile. And tadalafil and vardenafil are long-acting agents with good side effects profile and advantage of ease in administration. Both tadalafil and vardenafil can be used once a day, and while sildenafil is given 3 times, has to be given 3 times a day. So again, vasomodulators and liver transplant for portopulmonary hypertension, evidence from a systemic review and meta-analysis. So this meta-analysis published in Hepatology overall has shown that there is a odds ratio of 3.5 risk in more in vasomodulator group versus vasomodulator versus transplant. So there is a risk of 3.5 times in pure vasomodulator therapy group versus combined therapy of vasomodulator plus transplant. So one more recent study showing the efficacy of macitentan. Macitentan improves risk categorization of liver transplant mortality in patients with portopulmonary hypertension. So in this study, 10 milligram of macitentan was used for 3 months, and they were able to show that there was a risk reduction from 14% to 47% in macitentan group as compared to placebo, as well as wait list. So macitentan 10 mg with lesser side effect profile. So there are few myths and realities of portopulmonary hypertension. A myth is portopulmonary hypertension and hepatopulmonary syndrome are mutually exclusive. In fact, the reality is intrapulmonary vasodilatation is common in portopulmonary hypertension patients also, and the concomitant diagnosis of POPH and HPS are increasingly being recognized. And the intrapulmonary vascular dilatations, the IPVD, is one of the characteristic features of HPS, is common in portopulmonary hypertension group with a prevalence up to 60%. Another is, little is known regarding the pathophysiology of POPH, but nowadays, recent there are studies which are able to link development of portopulmonary hypertension to the sex hormones, to the inflammation, diminished bone morphogenetic proteins 9 signaling. One more is there are no prospective randomized controlled trials in POPH. So as we have seen that this trial in the phase 4, they were able to show that risk reduction in pre-transplant period, and there is a reduction in pulmonary vascular resistance with 10 mg per 10 mg OD dose of this macitentan, and with lesser side effect profile. Mean pulmonary artery pressure must be less than 35 mmHg to enable a safe liver transplant. Again, now they are saying these days they are able to show that safe and successful liver transplant can still be accomplished in the setting of mean pulmonary arterial pressure more than 35 mmHg, but with documented reduction of pulmonary vascular resistance to less than 240 dynes and S. So they say that with reduction of pulmonary vascular resistance, there is an enhanced flow in the pulmonary arteries, which can lead to false rise in mean pulmonary artery pressure. So coming to hepatic hydrothorax, seen in 5 to 10% of cirrhotic patients, and it is defined as the accumulation of transudate in pleural space of patient with cirrhosis in the absence of cardiac, pulmonary, and pleural diseases. So formation is secondary to small diaphragmatic defects, more often located on the right side, through which ascites moves into the pleural space because of negative intrathoracic pressure. Hepatic hydrothorax can lead to respiratory failure and can be complicated by spontaneous bacterial infections and associated with poor prognosis, median survival of 8 to 12 months. So diagnosis: once pleural effusion has been ascertained, cardiopulmonary primary pleural disease should be excluded by standard clinical approaches. Diagnostic thoracentesis is required to rule out bacterial infections. Presence and extent of diaphragmatic defects can be assessed indirectly by radioisotope techniques or directly by MRI imaging or color Doppler ultrasonography. So these are pleural fluid analysis. Any pleural fluid having serum to pleural fluid albumin gradient more than 1.5 or fluid total protein less than 2.5 or ratio less than 0.5, and they are that means the uncomplicated pleural fluids, they and with PMNs more than 250 or more than 500, they should not be there, otherwise that will be complicated. So treatment of hepatic hydrothorax: first line management relies on the treatment of ascites, that is with diuretics or large volume paracentesis. Therapeutic thoracentesis is required to relieve dyspnea. Repeated thoracentesis, however, can cause complications of pneumothorax, pleural infections, soft tissue infections, and bleeding. Whenever indicated and possible, liver transplant represents the best option for patients with refractory hepatic hydrothorax. TIPS has been effectively employed as a definitive treatment or bridge to transplant. Pleurodesis can also be offered to patients who are not candidates for TIPS or liver transplant. A recent meta-analysis has showed that pooled rate of complete response rate after pleurodesis is 72%, and but again with the complications of nearly same as high as 80%. Thoracoscopic repair with mesh is also a modality where there are large diaphragmatic rents. So about the post-LT outcomes, post-LT outcomes are similar between patients with and without hepatic hydrothorax. Hepatic hydrothorax resolution occurs within 3 months post-liver transplant. No significant difference in duration of post-operative mechanical ventilation or other supportive measures is observed. Hepatic hydrothorax is considered an indication for LT, and no standard exceptions for hepatic hydrothorax are given, except in cases of chronic recurrent hepatic hydrothorax. Non-standard mild exceptions can be given on individual basis. Disease: now coming to the disease that affect both liver and lungs. So there is in this table, there is a broader picture of all of the disease which can have both pulmonary as well as liver effects. They can directly affect both liver and lungs. So in this cystic fibrosis and stage liver disease, portal hypertension are the complications, and these are the indications. When simultaneously poor pre-LT lung functions, that is defined by FEV1 of less than 30, and that is very severe obstruction, they are contraindications. In the alpha-1 antitrypsin deficiency, And again, in most of these, alpha-1 antitrypsin deficiency, hereditary hemorrhagic telangiectasia, sarcoidosis, and stage liver disease and development of portal hypertension are the indications for liver transplantation. And in hereditary hemorrhagic telangiectasia, it is presence of intractable high output heart failure is also leading to acute liver failure is also an indication. Severe pulmonary development of severe portopulmonary hypertension is contraindication. Sorry, pulmonary arterial hypertension. So mild exceptions related to pulmonary disease in LT candidates. In cystic fibrosis, yes, mild exceptions are given if FEV1 is less than 40%, and in other countries varying. In alpha-1 antitrypsin deficiency, no mild exceptions are given. So coming to the conclusion, post-liver transplant survival outcomes depend on the indication and urgency, recipient age, donor characteristic, and retransplant status. Comparable survival rates are observed in patients with and without hepatic hydrothorax. So this is hepatic hydrothorax is considered an indication for LT. Chronic recurrent hepatic hydrothorax, despite optimal medical therapy, could be considered on an individual basis for non-standard mild exceptions. In hepatopulmonary syndrome, hypoxia is generally progressive and post-LT outcomes are worse in very severe cases. Given that LT cures HPS, the disease and indication for LT and standard exceptions apply to severe cases. In portopulmonary hypertension, post-LT outcomes can be unpredictable and mortality increases with the worsening portal hypertension. So vasomodulators are key in reducing pulmonary pressures, and standard exceptions can be requested in the aforementioned categories. Post-LT outcomes in cystic fibrosis, alpha-1 antitrypsin deficiency, hereditary hemorrhagic telangiectasia are comparable to outcomes reported in general LT recipient population. Standard exceptions can be requested for cystic fibrosis and high output heart failure in HST. Outcomes in sarcoidosis are poor as compared to even as compared to HPS. So no clear data are available with regard to post-liver transplant survival in asthma, COPD, pulmonary nodules, and interstitial lung disease. Evolution of lung function post-LT is determined by natural course of disease. Thank you, sir.